Hi, it's me again. My name is Irtaza Asar, and I am one of the core faculty members as well as the clerkship director at the AHN St. Vincent Emergency Medicine Residency Program. I am also the host of a medical education podcast called The Learning Curve. In this talk, we're going to be covering neurotrauma. This is a very tough topic, but I hope I can try to make this a little bit easier for you so I can set you up and your patients up for success. So let's dive right into it. Let's start with the case. You have a 47-year-old male that's brought to the ED after a high-speed MBA. He was the restrained driver of a car that struck a tree. Airbags were deployed. He was alert at the time of evaluation, but he did endorse to EMS that he was having neck pain and numbness in both hands. There was no loss of consciousness. EMS did immobilize his spine and transported him in a collar as well as a backboard. He has no prior medical history. He's on no medications. On your exam, his vitals are stable. He does have some midline cervical spine tenderness. His strength is 5 out of 5 in all extremities, but he does endorse that he is still having bilateral paresthesias of his hands. The questions that I want to pose to you that I'm also going to try to answer during this talk are, number one, what imaging is indicated at this time? Number two, what is the significance of bilateral hand paresthesias with preserved motor strength? And then number three, what are the red flag signs for unstable cervical spine injury in this case? So let's get started. When we talk about serious neurotrauma, we're talking about an event that has a high energy potential. And this event can potentially lead to cervical and lumbar spine fractures. It can lead to spinal cord injury, and it can even be from severe head trauma, and that can include either blunt or penetrating head trauma. Why do we care about this? The reasons are, number one, this has significant life-threatening potential for our patients. There's significant permanent disability risk as well, and these patients can get high morbidity and high mortality without timely interventions. So really, from our standpoint, we want to make sure that we can stabilize their airway, their breathing, circulation, and I'm going to add the word N for neuroprotection. That's going to be key, and we're going to dive into that as well. When we talk about reasons as to how our patients can experience serious neurotrauma, typically the most common is motor vehicle collisions. They can also occur in the setting of falling from significant heights. They can occur in the setting of firearm injuries, sports collisions, as well as blast injuries as well. They do tend to have a significant socioeconomic impact. Significant neurotrauma is the leading cause of disability in our younger patients. And for these younger patients, it means extensive rehabilitation. It may also mean being dependent on an assistive corrective device for a prolonged period of time to help with their activities of daily living. And again, that this potentially means lifelong costs, not just for the patient, but also enormous health costs for the healthcare system. And just to show the impact of that, there was a study that was published in JAMA, and this was published from Canada. And the question that this study asked was, what are the labor market consequences of traumatic brain injury for tax filing Canadian survivors 3 years after their initial injury event? This was a study that was conducted from 2007 to 2017, and they enrolled over 18,000 patients. What they found was the more severe the traumatic brain injury, the higher the likelihood was for unemployment for the patient as well as personal income loss. They actually estimated that the national cost of all of this over this 10-year time period for Canada was around $588 million. If you're looking for a US conversion, that's around $435 million. So this can be so significant, but why is it so significant? How does all this damage happen? Let's talk about pathophase. So typically there's an initial insult, and this initial insult leads to mechanical disruption of tissues, eventually causing direct neuronal cell death. Examples of this initial insult can be things like spinal cord transection, penetrating injury, and diffuse axonal injury. Once this primary injury gets set in, that's when the secondary injury starts, and what I like to call the three terrors that come to play, specifically ischemia, inflammation, and edema. Our goal here is to try to minimize the damage that these three terrors can do to our patients. Really, this can extend from minutes to hours and potentially days for our patients if we don't manage these three terrors well. The goal is to interrupt them as soon as possible with targeted interventions. What that includes is preventing hypoxia and hypotension. You're going to want a high MAP for your patients, MAP higher than 80. You want to keep that oxygen saturation above 94%. You want to manage their intracranial and intraspinal pressures, and that could mean simply elevating the head of the bed if you're suspecting an ICP elevation, or starting them on sedation, or starting them on agents like mannitol or hypertonic saline. You want to initiate neuroprotective measures as soon as possible. That means avoiding hyper or hypoglycemia and avoiding hyper or hypothermia. In terms of the imaging tools that we have at our disposal, we've got two, CT and MRI. CT is fast. It's got a high sensitivity for fractures. But the problem with CT is it can miss ligamentous injury and it does expose our patients to radiation. MRI, on the other hand, is great for ligamentous damage. There's no radiation exposure to our patients. It's great for assessing for spinal cord damage. But the problem is it's not readily available, so you really want to be watchful for that. And I would consider getting whole body CT or quote unquote pan scans, which typically includes a CT head, CT cervical spine, chest, abdomen, pelvis, as well as thoracic and lumbar imaging from reconstruction if I'm concerned for multi-system trauma. When we talk about penetrating head trauma, we're talking about some kind of object that breaches the skull and causes massive tissue disruption. It can also cause infection. It can also cause significant hemorrhage. Examples of this include a gunshot victim or significant blast injury. So what's our initial approach in this situation? Again, it's going to start with the ABCs. If their GCS is low, we want to try to stabilize them as best as we can. And we want to try to get hemorrhage control. From an imaging standpoint, we're going to try to get them over to our CT scanner as fast as possible, and we may consider a CT angiogram if we're concerned about some kind of vascular injury. We also want to get our consultants, specifically our neurosurgeons, on board early. They're going to help us manage any kind of significant bleeding, and they're going to also potentially help with any debridement or dural repair that the patient may end up needing. Now, let's segue over to blunt head trauma. There's 3 skull fractures that I want you guys to be aware about. Number 1, basilar skull fracture. The idea here is you're looking for things like battle sign, which is mastoid bruising. You're looking for things like raccoon eyes, which is periorbital ecchymosis. And you're looking for any kind of CSF that's leaking from the ear or the nose or just any place where it shouldn't be leaking from. We're talking about depressed skull fractures as another one. These tend to be high impact. They can compress and lacerate the underlying cortex. And then you've also got your linear fractures, which generally are less severe unless they start to cross any vascular groove or sinus. With regards to blunt head trauma, we also want to be watchful of diffuse axonal injury. And the key here is you're worried about significant rotational forces, and that can happen in high-speed MVAs or falls. And the idea here is that you can get significant shearing of the axons, and this can mean coma or significant cognitive deficits for your patients. The key that I want to stress is that for diffuse axonal injuries, your CT may be normal initially. Your MRI is going to be more sensitive for microbleeds and shear lesions. Now, let's just quickly review intracranial hemorrhages, and we'll talk about some management strategies with these. When we talk about epidural hematomas, we're talking about arterial bleeds, typically from the middle meningeal artery. These are lens-shaped, and these patients will classically have that lucid interval where they're awake and talking, and then all of a sudden they're deteriorating neurologically. We've got intracerebral hemorrhages, and we've got subdural hemorrhages, which are generally venous in origin from the bridging veins. And on your CT imaging, you're going to see that classic crescent-shaped. We typically see this in our elderly patients and also our patients with alcohol use disorder. Our management, again, I'm going to sound like a broken record, but ABCs are going to be key. We're going to want to know what anticoagulant the patient has on board, because that's also going to dictate our reversal strategy, especially for life-threatening hemorrhages. And again, this might also be a conversation with you where you have with your pharmacist and ask them, hey, what do we have available in the event that a patient's on Coumadin? Do we have 4-factor PCC at our site, right? So that's, again, a very important conversation to know what agents you have at your facility. You're going to want to control their blood pressure. Typically, that means systolic under 140. You're going to monitor their ICP, especially if their GCS is below 8. You may consider sedation to try to reduce the metabolic demand on the brain. And you want to try to initiate neuroprotective measures like trying to avoid hypoxia and hypotension as best as possible. And really, the big key is get your neurosurgeons on board early. Your neurosurgeons may consider doing a decompressive craniectomy. But why? The idea here is that your patient has critical ICPs and the brain needs some space or otherwise it's going to herniate. The way they're going to do this is they're going to remove a portion of the skull and they're going to then store that somewhere else. And then eventually, once the edema has subsided, they'll come back and do a cranioplasty once the edema is completely subsided. This is typically done when your ICP is critically high, and this is a last resort. To be quite honest with you, this does have controversial outcomes in the studies. In some studies, it has been shown to be life-saving, and in some studies, it has reduced mortality. But again, this is going to be dependent on what your neurosurgeon recommends at the time of the evaluation. So when we're talking about ICP, the normal ICP is around 5 to 15. Anything higher than 20 to 25, that's when you get a risk of decreased cerebral perfusion. And this idea is predicated on something called the Monroe-Kelly doctrine. And that idea is that the brain is inside this cranial vault, which is a fixed space. So when you start to get a lesion like bleeding, or a space-occupying lesion like a big tumor, the brain can compensate for that to some extent, but again, it's in that closed space. So there will come a point where the ICP will rapidly increase, and that's going to eventually lead to brain herniation if it's not addressed rapidly. So what are we trying to do? We're trying to keep our ICP under 20. We want to keep that cerebral perfusion pressure high. They say happy wife is happy life, but I say happy brain is happy life. And the idea here is that you want to keep that cerebral perfusion high. And to do that, you want a high MAP and you want a low ICP, because the equation is perfusion pressure is equal to MAP minus ICP. And if you have a high enough MAP, you may be able to overcome that elevated ICP. So these patients may potentially end up needing monitoring. So what does that mean for us? So if the patient has a GCS less than 8, they have significant ICP increases that's causing that, they may potentially benefit from ICP monitoring. You may also consider, based on your CT findings, that this patient, hey, has high risk of swelling or hematoma expansion, and I really need to be watchful of that. And your neurosurgeon may say, hey, that's another indication for trying to get ICP monitoring on board. If they're already receiving guided therapy like mannitol, hypertonic saline, deep sedation, they may benefit from ICP monitoring as well, just to see how your guided therapy is doing. So what do we have at our disposal? So our neurosurgeons may consider placing an extraventricular drain, which can drain CSF, it can measure ICP, and it can also be therapeutic in some cases. Or they may choose for a more invasive form of ICP monitoring by either placing a fiber optic or a probe in the actual brain tissue itself. From our standpoint, we're going to try our best to initiate therapeutic measures to help these patients. That can mean mannitol and hypertonic saline. And again, this is a conversation to have with your pharmacist. What do I have available at my facility? At my facility, we have mannitol more readily accessible, so I tend to gravitate towards that. But ask your pharmacist what you have available at your site. The easiest intervention to help lower ICP is get that head of the bed elevated. You want that head of the bed at around 30 degrees, and that's going to help to decrease your ICP. In terms of sedation and analgesia, we've got a couple of choices. We got propofol, we got Versed, we got fentanyl and morphine. I love propofol because it's quick on, quick off, so you can get that neuro exam very, very quickly. And then again, try to avoid any fevers, because the literature shows that even having a single fever while in this acute phase can actually worsen outcomes. And it makes sense, right? Because fevers are going to increase the metabolic domain on the brain. So you want to definitely try to prevent that. A couple of advanced therapies to be aware about. In patients that have refractory ICP, they may end up in a barbiturate coma. The idea is we're trying to reduce the cerebral metabolic rate as best as possible. The risks of this include things like hypotension, immunosuppression, and you're also committing your patient to continuous EEG monitoring as well. And as a last resort, we have decompressive craniectomy at our disposal through our neurosurgeons, again, something that we talked about previously. So when we talk about our neuroprotective strategies, we're going to, again, want to try to avoid hypotension, keep that MAP up. Glycemic control-wise, we want to maintain euglycemia. We want to avoid hyperglycemia, which I define as a blood sugar higher than 180 in this situation, and or avoiding hypoglycemia, which again I define as a blood sugar less than 70. We want to make sure that these patients' electrolytes are stabilized, specifically their sodium, calcium, and magnesium, so that we can keep that seizure threshold elevated and prevent further seizures for our patients. And then again, keep that temperature under control. Avoid any fevers and avoid hypothermia, because shivering in its own right can actually increase your ICP as well. Now, just as a refresher, we touched on this a little while ago. Epidural hematomas are arterial in origin, typically from the middle meningeal artery. These patients are going to have that classic lucid interval and then subsequently have a rapid crash if this does not get timely addressed. Your neurosurgeon may consider doing a burr hole or a craniotomy, and that's going to be predicated on whether your patient has a large volume hemorrhage, if they have significant midline shift, if they have worsening GCS, or if they have signs of herniation. From a prognosis standpoint, time is brain. If this gets evacuated early enough, our patients are going to have really good outcomes. If it doesn't get evacuated early, our patients potentially can have irreversible damage or even death. What about subdural hematomas? So subdural hematomas, as a refresher, again, venous bleed, these do cross suture lines. They have high mortality if they are large or if there's significant midline shift. Your neurosurgeon may consider taking them to the OR if the bleed is more than 10 millimeters in thickness, if there's more than 5 millimeters of midline shift, and if the patient's having rapid GCS changes. They may employ things like burr hole or craniotomies, but again, the key that I want to stress here is timely intervention is going to be very, very important. Time is brain. All right, let's segue over to blast injuries. So when we talk about blast injuries, we're talking about 4 different types of blast injuries. There's primary, secondary, tertiary, and quaternary. When we talk about primary blast injuries, this is when, because of the overpressure that's happening at the time of the event, that's going to affect your air-filled organs. This can lead to significant barotrauma as well as diffuse axonal injury. When we talk about secondary injuries, these are injuries that are happening from the shrapnel or the debris that are getting tossed, and that can lead to penetrating injuries to either the head or the spine. When we talk about tertiary injuries, we're talking about the victim is being thrown against hard surfaces and the blunt trauma that leads to other injuries like skull fractures or contusions. And then when we're talking about quaternary injuries, we're worried about burns, inhalation injuries, and crush injuries as well. These are complicated, and I'm going to be very honest with you. They're very challenging to manage because these patients are at significant risk of polytrauma that can eventually lead to hemorrhagic shock, crush syndrome, or open fractures. From our management, we want to make sure that we initiate TBI protective measures as soon as possible. We control the bleeding as best as we can, and then we have our surgeons and our trauma team on board for any debridement or burn care that these patients may end up needing as well. So from a neurotrauma standpoint, we again want to keep that map up high for the cerebral perfusion pressure. We want to do frequent neurochecks to make sure that these patients' GCSs aren't changing, and we want to make sure we've got appropriate sedation on board as well if we're worried about ICP increases. From a hemorrhage control standpoint, this is going to be a conversation with your trauma surgeons and seeing kind of what they need to do if they have to control bleeding. That can mean a laparotomy, that can mean a thoracotomy. And we want to assess for other injuries as well. For chest trauma, we want to assess for pulmonary contusions and flail chest. We're going to want to assess for any intra-abdominal injuries like liver lacerations, splenic lacerations, and then long bone fractures also can be a problem because they can increase the risk of fat embolism for our patients. And again, we stressed this before, but we want to try to maintain that normal temperature because if they get below 36 degrees and they start to shiver, that can increase their ICP. If they're hyperthermic, that can actually worsen secondary injuries and also raise the metabolic demand that's there on the brain. One of the questions that frequently comes up here is, what about seizure prophylaxis? This is going to be a conversation with your neurosurgeon, and it's going to depend on the culture at your facility. A lot of neurosurgeons will like initiating seizures, especially for a seizure that occurs after trauma. And typically the highest risk is within 7 days of a major head injury. When it comes to longer prophylaxis, that again tends to be a very controversial question, and that decision is going to be made in conjunction with your specialists. They may consider initiating something if your patient's having repeated seizures or they have an abnormal EEG. What about prognostication? So when we talk about a couple of prognostic markers, I want to make sure that you guys are aware of these. A low initial GCS, fixed dilated pupils, systemic hypotension, systemic hypoxia, a patient that's older with other injuries as well as with multiple comorbidities, they're going to have a worse prognosis as compared to somebody that doesn't have these factors. There's a couple of prognostic factors that I also want you to be aware of on imaging findings. If they have a large extraaxial or intraparenchymal hemorrhage on CT, or they have significant midline shift, and or if they have diffuse axonal injury on MRI imaging, that's again a poor prognostic marker as well. One of the things that I also want to stress is that patients that end up having significant traumatic brain injury, they're at a higher risk for developing PTSD. And when I think about this in violent trauma or military patients, and the way they can present later is with flashbacks, hypervigilance, and nightmares, and that can really complicate the recovery process. So I always try to make sure that we can get our multidisciplinary team involved, especially early on, so we can make sure that we're addressing the needs of these patients. That can include things like collaborating with our mental health professionals and also possibly pharmacotherapy as well. All right, let's segue over to spinal injury. So a couple of quick pearls about the different spinal injuries. When we talk about cervical spinal injuries, this is the area where you're at highest risk for airway compromise, especially if it involves the diaphragm innervation at C3 to C5. There's also potential for quadriplegia as well if the lesion is high enough. When we talk about thoracic spinal injuries, these are less common for complete core transection unless there's high energy trauma involved. And when we talk about lumbar spinal injuries, we get worried about cauda equina, especially if it's a lower lesion. When we talk about sacral spinal injuries, we're talking about possibly bowel or bladder dysfunction and also saddle anesthesia. This can occur in a wide variety of clinical settings. Specifically, the most common is motor vehicle accidents. It can also occur in falls and sports collisions. Our priority is we want to make sure that that airway is stabilized, especially if we're worried about some C-spine involvement. And again, immobilization is going to be key, especially if you can't localize what level the spinal injury is at as well. When we talk about spinal injury classifications, this classification scheme is one that I would definitely be aware about. This is the American Spinal Injury Association scale. And the idea here is that your patients are given a number, and this number is predicated on their motor and their sensory ability at the time of your exam. So the motor is divided into 10 muscle groups, 5 in the upper and 5 in the lower, and each is scored from 0 to 5. From a sensory standpoint, they have 28 dermatomes that they're assessed in terms of light, touch, and pinprick, and that's scored from 0 to 2. Ultimately, you don't have to know how they score it, but the end result is they get a score, and based on that, they get a classification scheme. If they get grade A, that means that that patient has a complete injury, and specifically that means they have no sensory or motor function that's preserved at the S4, S5 level, whereas E just basically means they're normal, and they have motor and sensory that is now preserved. When we talk about prognostic value, Class A means the worst prognosis, Class D and E have the best prognosis. This is typically done after your spinal shock does resolve, and that means around 24 to 72 hours after the time of injury. This is going to help guide our PT/OT specialists and what kind of plans they come up with. It may also guide if this patient ends up needing bracing or potentially surgical decompression as well. When we talk about the words spinal shock and neurogenic shock, these are two words that are quite often interchangeably used, but they're not actually the same thing. Neurogenic shock essentially refers to a disruption of sympathetic outflow, and that's where our patients get hypotension and bradycardia, and we see this typically in the setting of cervical and upper thoracic injuries. Spinal shock, on the other hand, refers to an acute loss of reflexes that occurs below the level of the spinal injury. These patients are typically showing up with flaccid paralysis, areflexia, and initially they may not have any motor or sensory function. I really like this diagram that kind of talks about spinal shock, and the idea here is, again, in that immediate phase when that spinal shock sets in, we really have a limited amount of time to try to reduce cell death as best as possible and also initiate neuroprotection. Because eventually what will happen is that the patients will end up in that subacute and chronic phase where they start to get that glial scar matrix formation, and then eventually they'll have repair through neuroplasticity. The clinical implications of spinal shock there's a couple of clinical implications that I want you guys to be aware about. Your early ASI exam can be misleading, so you really want to give them a proper chance and wait for those reflexes to return before you make that definitive prognosis. You want to maintain perfusion during this time period to avoid any further damage, because remember, those 3 terrors are always lurking behind us, and we want to try to stabilize that spine during this time period, again, to prevent further damage. So let's dive into some spinal cord syndromes. When we talk about anterior cord syndrome, this essentially refers to an injury to the anterior 2/3 of the spinal cord. The injury mechanism that's most commonly implicated is typically a hyperflexion accident, and you'll see this in diving patients that are diving from a high height. The clinical features that I want you to be aware about is that these patients will have complete paralysis below the injury level. They'll have pain and temperature loss below the lesion, that's bilaterally. What they will have preserved is their vibration and proprioception. From a management strategy, ABC is going to be key. We're going to want to maintain that high MAP to keep that intraspinal pressure up so that we're having good, strong perfusion. Imaging-wise, if you have access to an MRI, that's excellent, because really you want to get that MRI as fast as possible to evaluate for the extent of ischemia and/or infarction. Steroids really don't have a role as per the 2013 AANS/CNS guidelines. Anterior cord syndrome does tend to have the worst prognosis out of the 3 spinal cord syndromes that we're going to talk about today. About 10 to 20% of our patients are going to achieve meaningful recovery. This is going to lead to significant paralysis and sensory loss. So for us, really the key is early recognition and trying to get these folks set up for rehab so that they can adapt to their new life and essentially help to improve their quality of life moving forward. What about central cord syndrome? This is a central spinal cord injury that's typically seen at the C4 to C6 level. The injury mechanism that's the most commonly implicated is a hyperextension injury, and you'll see this in patients that have significant spondylosis, and that's typically your elderly patients that'll have a ground level fall. The key here is that the upper extremity weakness is going to be more profound in comparison to the lower extremity weakness. These patients, like our patient at the start of the case, they may have variable sensory deficits, in particular in the arms and the hands. Urinary retention may also be seen as well. Our management, again, is very similar. We want to stabilize those ABCs. We want to maintain that MAP above 85 to 90, and we want to get that MRI done as soon as possible to see the extent of ischemia or infarction. Steroids, again, don't have any real benefit here. The prognosis is a lot better than anterior cord syndrome. These patients, they're going to have significant recovery. About 60 to 80% of patients will make complete recovery. And the recovery order is generally the lower extremities, followed with the bladder, and then followed with the upper extremity. The patients that potentially can end up having worse outcomes are the ones that are older than 65 and that have severe initial deficits. The last spinal cord injury syndrome that we're going to talk about is Brown-Séquard. The idea here is you have a transverse hemisection of the spinal cord that is completely taken out. And you generally see this in the setting of penetrating trauma. You can also see this in the setting of spinal epidural hematomas. The clinical features that I want you guys to be aware about is from a motor standpoint, you have ipsilateral motor paralysis. And in terms of sensation, you have loss of proprioception and vibration on the same side as well. On the opposite side, you'll have loss of pain and temperature. Our management strategy is going to be the same. ABCs, maintain that high mean arterial pressure, typically higher than 85 to 90. And then you want to get that emergent MRI as soon as possible to really categorize how much damage there is. Steroids, again, don't really have any routine benefit in this clinical scenario. These patients will have the best prognosis. Up to 75 to 90% of patients will have good functional recovery. And that timeline is going to be your proximal muscles, followed by the distal muscle groups. Here's a quick reference table that I created that you can always reference on your shifts. The idea is that the Brown-Séquard patients are going to have the best prognosis, central cord patients are going to have average prognosis, and then anterior cord syndrome are going to have the worst prognosis. With regards to Brown-Séquard, you're going to typically see that in a penetrating trauma setting, and then central cord, you're going to see that with a forced hyperextension mechanism, especially in our patients that have spondylosis and they have a ground level fall. And then with anterior cord syndrome, that's going to be either a flexion injury or some kind of vascular problem that's going to lead to the key clinical points that we talked about as well. Thank you so much for your time. See you guys for the next talk.